Welcome back. And in this mini lecture, we are going to learn about bony fractures and their repair. So to get started, let's talk first about bone mass. So as you're a child and you enter adolescence and early adulthood, because of your increasing physical activity and good dietary habits, you're actually creating more bone mass, okay? By the time you're done with college, it's pretty much all downhill from there. And you're going to be losing bone. So here's the good things to talk about that. Your peak bone mass is about your mid-20s to your late 20s. So it's super important that you do everything you can in your diet and in your exercise habits to make it as dense as possible. After that, you cannot bring it up to the density you had. It's always going to go down from that point on. If you look at these graphs, the blue one, which you will notice over time, by the time men reach about 85 years of age, they have lost about a quarter of their bone density. Whereas if you look at women, our bone density is not as much as men. But if you look, we don't really have our drop until we hit our 50s. And the reason for that is before menopause, we have high estrogen levels. And the estrogen levels induce apoptosis of osteoclasts, meaning it causes osteoclasts to die. So we are not breaking down as much bone. Now, once you hit menopause, you don't have those estrogen levels anymore, and these osteoclasts are going to become very active. So we have a very rapid decline initially, and then our level of decrease is slower than the men. However, the damage has been done, and we're going to lose about a third of our bone density. So it's super important in your 20s to be physically active and have the proper diet and make your bones as strong as possible. I also want to point out that if you're a smoker or living with a smoker, you are going to have a lesser bone mass. All right. So what does it mean when you're losing the bone mass? You have this disease called osteoporosis where the bone density has decreased. And so normal scanning electromicrograph is on your left, and a scanning electromicrograph of somebody with osteoporosis is on the right. And as you can see, just looking at the spongy bone, which is where the osteoporosis is most prevalent, the spongy bone has little holes in it, okay? And the reason why spongy bone is affected more than compact bone is because its turnover is more rapid, it's more metabolically active, therefore it's more susceptible to influences. And these little bones will become brittle. You can get microfractures in there. So what are the risk factors for osteoporosis? Well, sitting around not exercising, because remember, do your swimming to get bone remodeling going on. If you're a white woman, if you're a smoker, if you have a low body weight, if you have a low protein intake, if you drink, ladies, more than 1 drink a day, men more than 2 a day. If you have a family history, if you have diabetes, if you have menopause early, if you're breastfeeding and not taking supplemental vitamin D, all of these things put you at risk for osteoporosis. So even if you do the right things in your 20s, ladies, when you have your babies, you need to realize you need to up your intakes, because that baby is like a leech, both when it's inside you and when you are breastfeeding. You are giving your stuff to the baby, and your body is suffering as a result of it. All right. So who gets osteoporosis? Well, about 80% of the people with it are women. And it's very common among certain women, young women who run. Okay, so your track and field, your cross-country athletes, also dancers and your gymnasts. And gymnasts, you know, they got that double whammy of they have that very low body weight. Okay. Astronauts, of course, because they're in outer space, they're not having the effects of gravity, so they don't have any pull on their bones at all. And anybody who had a lower bone density at a younger age is much higher risk for osteoporosis. So anybody who had a chronic disease as a child or a young adult, if they were hospitalized, if they were sedate for a long time, if they were quarantined for 6 months to a year and didn't get any kind of regular activity, you're more at risk for osteoporosis. I put a list here of some medications just for you to realize there's a whole slew of medications that can affect this. But before you blame it on medication or blame it on disease, look at that list in the middle. And please don't try to memorize this list of the blue stuff. Look at the list in the middle. Those are the important things, the risk factors for osteoporosis. So why is it bad to have osteoporosis? Look at the pictures in the top middle. On the left is normal spongy bone, and on the right are the very thin pieces of osteoporotic bone. So the spicules have really narrowed down, and they're so narrow. You notice there's so much more space to them that they can't even hold your weight anymore. And you get microfractions. And if they're weight bearing, you get compression fractures. So on the top right, you can see what happens to your spine. If you're upright, they're all kind of rectangular in space. But realize we have normal curves in our spine, and so they're not stacked like this. We actually have these curves, which means we're going to have more weight anteriorly. And so what happens is they become wedge shaped, and then it's kind of like a building collapsing down on itself. Once it's swished one, then there's too much weight on that one. It's going to break more and more and more and more, and that's what leads to that kyphosis or that dowager hump. Now, another thing that a lot of people don't associate with osteoporosis, and they just think it's part of old age, is if this is happening to the bones in the spine, it's happening to the bones everywhere, and this is why when elderly people fall, they're more likely to get a fracture than a younger person. And it's also happening to the bone in your mandible and your maxilla, and so your teeth can become loose, and you could lose a tooth. Now, the important thing is exercise can reverse some of the bone loss. It cannot take you back to the way you were when you were in your 20s. It can't even take you back to the way you were when you were in your 50s and 60s. But it certainly can prevent further loss. All right. So let's assume you had a fracture at some point in your life, whether it's a fracture due to osteoporosis or it's just due to a fracture from trauma. All bone that gets broken, the repair is in 4 big steps. And I put all 4 of them on one slide, even though there's a lot of things happening in each of the 4 steps. So here's the picture of the broken bone. It's showing a long bone because there's a medullary cavity. And so this way we have some spongy bone and some compact bone. And so when the bone breaks, you have to remember, oh, bone has blood vessels. So if the bone broke, then blood vessels broke as well. And so you're going to have bleeding in the space where the fracture is, and you're going to have a blood clot that forms. So this bleeding is going to go for several hours. Okay? So like for 6 to 8 hours, the amount of blood that's going to go in there and form that blood clot is going to increase. And the word for a blood clot is called a hematoma. Heme has blood, oma means swelling. Okay, so basically a blood clot. And this is, a hematoma is not a blood clot in a broken bone. A hematoma is a blood clot anywhere in your body. Okay, so we are going to have a hematoma here in the area where the broken bones are, where the break is. Now the problem is, we don't want that hematoma there. And we have all these damaged blood vessel cells, we have all these damaged bone cells, we have all this debris. So in addition to the hematoma formation, which is part of step 1, there's actually kind of like 3 parts to step 1. Okay. In addition to the hematoma formation, now we have to have cleanup on aisle 3. We got to get rid of all this stuff that's there. And this is a process known as the inflammatory process. So we are going to have normal inflammation and cleanup. So when you learn about the immune system, you'll learn about the inflammatory process, and you'll also learn this takes about 7 to 10 days in a normal person. So the hematoma formation goes on for first third of a day. The inflammatory process is going to go on for slightly more than a week. And as part of that inflammatory process, at the end, your body is trying to return itself to normal, so you are going to develop what is called granulation tissue, which means we're going to have new blood vessels come into the area, and we're going to have new fibroblasts come into the area. The same sort of thing that happens, like for instance, if you scab your knee, that reddish stuff that you see growing in there, about a week later, that's granulation tissue. All right, so that's step one, hematoma formation, the inflammatory reaction, and granulation tissue. Step two is we need to build a bridge between the broken bone pieces, okay? Because we don't form a bridge, then we can't make a solid piece of bone. And what's going to happen are the fibroblasts that are here are going to start laying down collagen, and the osteochondral progenitor cells are going to get the message, become a chondroblast. And so the chondroblasts are going to start making new cartilage. And so we're going to have a cartilage bridge between the two bones, and you're going to be able to feel it and see it. And this is called a fibrocartilaginous callus, because it's fibrocartilage, all those fibroblasts with all that collagen. So we are going to have two pieces of bone, and between them, we are going to put some fibrocartilage, and that's going to hold everything together so it won't be moving around. And this takes about 3 weeks. Okay. So now we're about a month after the fracture. And this feels nice and hard because it's fibrocartilage, okay? But is it bone? No, it's not bone. But if you recall, one of the ways we make bone is from cartilage. And now we have a cartilaginous bridge. So that brings us to our third step, where we're going to change the fibrocartilaginous callus into a bony callus. And so we're going to create spongy bone that's now connecting the two pieces, all right? So if you look at that, now we have bone to bone to bone to bone to bone. The entire thing is bone. This entire process takes about 3 or 4 months. But what kind of bone do you see in the picture? That's right, it's spongy bone. So is that spongy bone as strong as the bone that was there before? No, but your cast is off. Okay, but you shouldn't be playing your sports yet because it's not normal bone yet. So the fourth step is bone remodeling, where now we have to take the spongy bone that was laid down all across the fracture. We need to make compact bone, and if it's in a long bone, we need to make a medullary cavity. So those are the 4 steps of bone repair. And so I ask you to go ahead and stop this slide, look at these pictures, and try to figure out what you see. Is there a new fracture? Is it an old fracture? How do you know it's new? How do you know it's old? How can you tell it's cartilage? How can you tell it's bone? How can you tell if there's an epiphyseal plate or it's not an epiphyseal plate? So remind yourself of all those things and spend some time with this slide, and let me know if you have any questions. All right. So that brings us to fractures. So when we're looking at fractures, we can divide them a couple of different ways. We can talk about a complete fracture, which is when a bone is broken into 2 pieces. And so a lot of you as children fell on an outstretched arm and you had a Cully's fracture with the arm cast, or perhaps you fractured your clavicle, and that would be another example of a complete fracture. If it breaks into more than 2 pieces, so whether it's 3 pieces or 5 pieces, we're going to call it a comminuted fracture. And so, for instance, the bottom left, this would be an example of somebody who was walking and hit by a bumper of a car, which is always really bad for your legs. The car always wins. Or on the right, somebody who was walking along, maybe on top of a fence, and then jump down because, hey, they used to do it all the time when they were a kid, but now, I'm sorry, you're a grandparent, you can't do that. Your whole vertebrae just kind of crushed down on itself. So that's a complete versus a comminuted. It just has to do with the number of pieces. Sometimes when the bone is fractured, the pieces won't be lined up normally, okay? The first is when they're lined up normally. That's called non-displaced. But if they're pulled out of alignment, we call that displaced, in which case we have to do something to reduce it back to the normal arrangement. And this third one in the bottom right, this is what we call an impacted fracture, where one piece, because we had a force that was going in one direction, typically on the long bone, it was going along the axis of the bone. And so it fractured the bone and it shoved one piece into the other piece. So the pieces are not separate from each other. And so they have to be pulled back apart and then realigned in their normal positioning. So that's the difference between displacement, non-displaced, and impacted fractures. Another way we classify them as simple and compound. In a simple fracture, bone does not protrude through the skin. And so here are some examples of some types of simple fractures. If we have a fracture at an angle, it would be an oblique fracture. Now, if it's at an angle due to a twisting motion, and you get the idea in this one on the right, you can see the twisting that happened in there, that we call a spiral fracture. If it is a fracture where we don't end up with two pieces because the bone was not calcified, had never been calcified, that is what we call a green stick or an incomplete fracture. So much more common in children because they have not been heavily calcified. And so it's the same thing as if you would take a stick off of a tree and try to break it, it wouldn't break all the way. But if you got it off the ground, it would snap in two. On the bottom here, this is a bad fracture because this is a fracture that is going through the epiphyseal plate, which means when it heals, you are going to be making spongy bone in the epiphyseal plate, which then means you're not going to have an epiphyseal plate for long bone, so this bone will not lengthen like it's supposed to. Now, in contrast to simple fractures, we have compound fractures, and they can be, compound fractures can be oblique or spiral as well. But what a compound fracture means, bone protrudes through the skin. So I've got some pictures. So if you're the kind of person that doesn't like those scary movies, you know, you can kind of cover it up and I'll let you know when we're done. So these are pictures taken from actual soccer game. And the grass was wet, and so the guy in blue slid, and I think you get an idea what's going to happen here. So I've got a couple more pictures. And so here you can see what's happening, and then you can see what's happening. You go to the emergency room, it looks like that, but not to worry. I'm sure there was a Cub Scout there who helped the person get off. All right. So I didn't want to stay on those pictures for a long time in case you did not like looking at pictures of compound fractures, which is why I had the drawing of a compound fracture so you could understand it from there. Okay. And with that, I have this slide, which has 6 different fractures on it. I want you to spend some time. I definitely want you to pause it. Do definitely pause it because I have the answers coming up, and I don't want you to see the answers until you have written down what you think your answers are for all 6 of these. Okay, so I don't want to have to sit here for 2 minutes while you're figuring this out. So pause it now. Okay. So thank you. I am going to give you the answers right here. And with that, we are done with this section on fractures. And thank you for all your hard work, and I will see you again soon.